So I must say that PPE has definitely been the number one FAQ since this has begun. And I guess what I would say is that things have changed since the outbreak began. And so with that change, I think things have been quite unsettling. So in terms of when things were first realised, there was one set of PPE that was advised, and then we've changed, and Public Health England have changed the PPE that's been advised. And I think there's a real perception that I think is understandable that is driven by resource limitation as opposed to science or understanding of the infection. So I think it's just helpful to kind of run through things a little bit. When the infection was first realised, it was classed as a high consequence infectious disease, meaning it was a novel infection that we hadn't seen before and didn't know how it was transmitted, what the case fatality was, what the secondary infection rate was, and so on. And now we have much more of that information. As of the weekend, Public Health England and WHO have stepped down this organism as a high consequence infectious disease. So it now no longer is deemed a high consequence infectious disease. So I think that's an important thing to say. The other thing to say is, as a trust, we are following guidance from WHO and following guidance from Public Health England. So we're not making this up ourselves. We're taking advice from experts in terms of PPE. And so in terms of the change in recommendations of PPE from initially wearing aerosol protection in terms of FFP3 fitted masks and gowns and visors and things, down to wearing an apron and a surgical mask and gloves, that is not resource dependent. That is because of a better understanding of the infection being droplet transmitted as opposed to primarily aerosol transmitted. So that change in PPE is driven by our understanding of the organism, not by resource. The second biggest question is about the importance of fit testing versus fit checking. So in those situations where you end up requiring to do aerosol generating procedures, of which the list is reasonably short, the recommendation from both PHE and from WHO is to wear an FFP3 mask. And there is debate and uncertainty about fit checking and fit testing. Fit testing is something that you do once with one type of mask to see if that type of mask fits you. That means when you go forward, you then know that mask fits your face and you can use that mask kind of going forward. The issue is that we've had different supplies of FFP3 masks kind of coming through, and so you fitted with one mask doesn't mean you necessarily fit another mask. And doing a fit test for PPE means that mask then has to be thrown in the bin. And so the move from fit testing to fit checking in terms of emphasis is resource related, in terms of there are not enough FFP3 masks to go around for everyone to be fit tested who needs to be. Now, going back to this does not mean that wearing a fit test mask that hasn't been fit tested is useless and doesn't work. The key thing is the fit checking, and fit checking is something you should do every time that you put on PPE. It's the process of donning. It's when you put on everything else, you put on the mask and you do your fit checking at the same time. That's been shown to be protective and beneficial, whereas there's interesting kind of data and studies suggesting that fit testing undertaken has no impact on acquisition of infection or outcome. And so fit checking is the thing that you should be doing as part of your PPE donning and doffing training. Because it will change with masks. We'll get different batch of masks in this week, we'll have a different batch of masks in next week. And so the key is each time you put on PPE, then it should be fit checked. And the key thing is, as well, it is only for those situations where you're in the face of kind of aerosol generating procedures. And the list of those is reasonably short. So it's intubation, extubation, non-invasive ventilation, high flow oxygen, and in the CF cohort, it can induced sputum. And bronchoscopy, yeah, exactly. And it's interesting, having looked in this quite a lot of detail, there's some really good references out there in terms of what constitutes an aerosol generating procedure, why they're deemed aerosol generating procedures. And actually, the data is reasonably limited. The data for AGPs, so aerosol generating procedures, is really strongest for intubation. The data for other things is far less robust, and so it's about kind of risk benefit. And so I would say we're sticking to the guidelines of PHE. There are some really nice posters in terms of what to do and how to do it. And we think we've now got a better understanding of the organism than we did even 2 or 3 weeks ago, especially from stuff coming out of Hong Kong and Singapore. And I think the thing to say is that it's likely that many people in this room will probably get COVID. That's a fact of life. But that if you look, I will try and circulate earlier, but some really interesting data in terms of your risk of severe infection requiring hospitalization, and then risk of severe outcome requiring ITU, and so on. And in terms of looking at the people in the room, the risk of any of those outcomes in terms of severe infection or requiring any form of hospitalization is kind of less than 1%. And so I would bear that in mind in terms of for healthcare workers, then it's likely that infection will happen, and when that infection is acquired is impossible to tell. People will always attribute infection to occurring in the healthcare setting, but equally, given the incubation was 2 weeks ago, imagine what you've done over the last 2 weeks that may end up, the sort of exposure you may have had over the last 2 weeks that may be the initiating event. So I just think, let's think about, a bit pragmatically about this, and let's kind of do the best we can with the resources that we have. So for most people, it is droplet PPE, which is surgical face mask, apron and gloves. For aerosol generating procedures, it is FFP3 mask, eye protection, long sleeve gown and gloves. And happy to take any questions.
I suppose I would add, a high index of suspicion.
Yep.
For anybody you come into contact with, so questioning carefully, and wearing the protection for if you have any concerns, wearing the surgical masks and gowns and gloves. And then finally, like me, ending up with raw hands. I've never had such raw hands in all my life. Every moment I'm just washing with soap and water. And whatever that stuff is you put on to try and make, was it fairy liquid or something? Yeah. Right, question?
Given our relatively high rates of getting COVID, is there any justification for wearing surgical face masks that you're just seeing?
Vulnerable patients in clinics or on the routine wards.
So the question for those who didn't hear was about, should we just be wearing face masks all the time, essentially? So that comes down to what we think is the rate of asymptomatic infection, I guess, in terms of what's the rate of people having and shedding the virus with no symptoms. So the key is, as Edward said, that the key index is low index of suspicion, and what we're hoping to do is anyone who's coming to clinic is triaged at the front door, and anyone with symptoms is diverted to a specific clinic. So Clinic 2 we've now set up into a COVID assessment clinic. So in terms of folk who come and see you in clinic should already have been triaged at the front door. And so the rate of carriage or the rate of infection in people who are asymptomatic in studies from both Germany and in Singapore is about less than 2%. It's about 1.5% of people you'll be able to detect coronavirus in their kind of secretions, I guess, when they don't have any symptoms. So that's the question. Okay. Oh, in terms of staff, that's a good question. So I think it works likewise in terms of if again, 2%, less than 2% of staff will therefore have coronavirus in their nose, but not be able and not be aware of it in terms of any symptoms. And I guess I would say, thinking about how it's transmitted, if you're sitting in clinic and you're breathing, you're not likely to be generating any aerosols or droplets and things. So the issue is in terms of, yes, we can detect it, but what's the transmissibility of that individual who isn't coughing or sneezing and things? Because it is droplet sort of stuff. If you have a cough or sneeze, then clearly, yes, it will kind of transmit. But I don't think at this stage that there is sufficient evidence of widespread asymptomatic carriage to justify wearing a surgical face mask for all interactions. And I guess this also comes down to, it's a science question, but it's also a resource question as well. So in terms of if we were to do that, then we would, again, quickly run out of surgical face masks.
I think quite a few of the anaesthetic colleagues sort of were a bit unsure as to the risk of transmission in asymptomatic patients that you're intubating. Is that the same as the asymptomatic patient that you see in clinic? I know that's a really difficult question.
Yeah, no, it's a difficult question. I mean, you're by definition going to have exposure to droplets and aerosol by virtue of the procedures that you're doing. Again, it's the same risk applies in terms of it's going to be 2% of the population or less will have asymptomatic kind of carriage. There's debates going on in terms of the surgical side of things, in terms of the elective admissions, whether they arrive and they're swabbed, and if they're swabbed and found negative, then they proceed to surgery or not. It's something we're working on, which would then mean that you know the person who's coming in has a negative swab, so then no symptoms, negative swab. You've got 2 negatives, which suggests the risk is much, much lower. Again, I would argue that wearing a surgical face mask for that gives you quite a bit of protection. It may not be as complete as kind of for aerosol things, but I would argue that a surgical face mask in that situation is adequate, is okay. The other thing we're thinking about doing is in terms of addressing the risk of those where we don't know. So say if there's an immediate transfer required and needs urgent surgery where we don't know, then the algorithm as we work it currently assumes COVID until proven otherwise, which means PPE for intubation. It's a good question.
An important point, I think that very important point. Assumes is. George.
Can I ask about the situation in cardiothoracic surgery of patients with chest drains and
Sure.
particularly air leaks in chest drains? Does that become aerosol generating?
No, I don't think. I'll ask. I'll check. But my understanding is that it doesn't. But it's a good question, and I will check just to see. So presumably, the risk is kind of.
So if you have
stuff in
an
the
air
lung.
leak, you've got a hole in your lung coming out into a chest drain into the room. Yeah.
And in terms of, excuse my ignorance, but in terms of anatomically, does that not go through an
It's
underwater seal?
seal, yeah.
Fine. Okay. So that I think would be an important bit as well, and it's often deemed the pressure with which stuff is expelled. So in terms of it's either being kind of face in when you're intubating someone, or it's things like high flow oxygen when you're blasting kind of 60 litres a minute. Whereas I think normal respiration through a leak would be the same as normal respiration through a mouth. But I will check. That's a really good question.
You're actually performing the surgery with ourselves if there's a leak in the lung during the surgical procedure.
Yeah, no, true. So I think I've talked a bit to Kelvin Lau about that, and in terms of the main thing is it's deemed that when you're doing most of your thoracic surgery, my understanding is the lung then collapses. You use a double image tube, the lung's then collapsed, and actually that lung is then isolated, and there's no leak from there. But you're right in terms of when there is a situation of a leak. I'll have a chat with Kelvin and we'll see. But thank you.
Yeah, a question about doctors being off sick, because
Yeah.
I think we're going to have quite a lot, probably more than normal, and I don't know what the thinking is about how fluid we are about going back and forth, because we want to make that as efficient as possible. Doctors having to call in sick at short notice, come in again well-ish at short notice, and how maybe we can put them to use at home, because speaking to some of my friends, they're kind of annoyed sitting at home feeling like they're useless, and 2, about maybe a single point of contact or something for doctors who are going back and forth, because I know we've got different rotas and different people coming back and forth, and we're COVID or not COVID at the moment, so maybe we need a single point of contact, something like that.
Yeah. No, good question. The question for those who didn't hear was about how to manage the fluidity of staff going off sick and coming back and going off sick. I think there is. I would speak more about it, but I think there's a big piece of work about staffing. From my point of view, there's a big question about staff. Testing is another FAQ that I get asked about. I think we just need to be careful about. It would be great. If I was unwell, I would want to know. For several reasons. One, it's just nice to know, and 2, it means that when I recover, I know I've had it, and that's a very valuable bit of information. The question comes down to the sensitivity of the test in terms of, does a negative test mean that you don't have it or didn't have it? I think what I would be more interested in looking at is in a month or two's time, when serology testing kind of comes out, knowing that did I have it? That was my flu-like illness I had 2 months ago. That was COVID. That I think will be more reliable than the nasal swabs and things. But in terms of staff fluidity, there is a big piece of work going on, I think, about staffing through Rocky Health.
I think there are a number of questions there. One is isolation, self-isolation, and the rules. Are you all clear about time? Yeah. Secondly, staff. It's important that if you do isolate or you have symptoms, that you contact your manager to tell them, and early you can do that in the day, the better. The staff testing, we are escalating daily the requirement for this. it is a capacity issue because there just isn't enough testing available. Patients, unfortunately, are a higher priority, so we need to know, both for them and also for you, do we have it? The capacity is being increased. I anticipate that a week today we will have the capacity to test staff. That's what I'm being told at the moment. I believe that there will be some testing this week at a low level, but they have already increased 10 times the amount of testing they're able to do here. And as Jonathan said, I think we're all waiting for the antibody, and my understanding as of this morning is that it's a matter of a few weeks away. Then there'll be so much, I think we'll all be so much happier to know that we have had it or haven't had it, and we can conclude from that some important things about our own safety.
Dr. Rowland, just to while everyone's here, many people would have heard about this, but just if you are calling in sick, as well as telling their team to make sure that the site manager's been informed as well, so that there's an awareness of overall sickness in the hospital.
Sorry.
I just wanted to ask, this is not a PPE question, I don't want to sound alarming, but I saw in the news over the weekend there were 3 30-year-old doctors in Northwood Park committed to ICU coronavirus and 2 ENT consultants up north. And I was wondering, is there any evidence of an exposure or viral dose-related extent of the severity of the disease?
So it's a good question. One, I would urge some caution. There was stuff in the press about us having to consultants on ECMO here, which was not true. So I appreciate there is concern, but there is also a degree of fake news around. But I won't question that. But just so I think there is some degree of exposure, and it comes down to some of the virology of it, and it comes down to the droplets versus aerosols. So droplets are large. They fall to the ground quite quickly. They get deposited in your upper airways. They do not travel down into the alveoli. And the theory is that where the infection lands, the infection begins. I guess the concern is more about aerosols. So if you've got small aerosol kind of particles, then they can end up traveling down into the alveoli, and that's when the infection can develop kind of with a pneumonitis rather than an upper respiratory tract infection. And so what I would say, this comes down to the idea of being aware of what are the aerosol generating procedures and protecting yourself during those times. So ENT, whether they're in tracheostomies and things, again, that's an aerosol generating thing, and ITU folk as well. So likewise, they'll likely be in situations where there was optoflow. And it'll be interesting to know whether this was impossible to know when the infection was acquired, and tracking back in terms of, was this before we knew much about COVID and exposures were happening, before we were screening patients? Because it's only been in the last couple of weeks that we've moved away from contacts and geography to base our screening to just thinking about everybody. So I wonder whether, if those individuals did unfortunately acquire the infection, it was in the setting prior to us having a heightened cough in order to transmit. So I would, while we work things out, I would have a reasonably low threshold for saying, okay, I've got a cough, or I've got a nasty kind of runny nose. Then there's always going to be a grade in terms of does one sniffle or does one cough mean I stay off work? It's going to be impossible to kind of completely kind of dictate that, and I would base it on kind of clinical judgment. If you kind of go, actually, I feel unwell, I don't feel great, this is different to how I normally feel, this is unusual for me, then I would use that as justification to say to stay away.
Stay away. I think that's a very sensible piece of advice. If you're in doubt, stay away. Things will become apparent in a day or two. Clarity in a day or two. Yep. You happy with that?
Yep. And if say a day or two later nothing's changed, it's not got any worse, we're not developing a cough, can we then come into work, or once we make that call cautiously, do we then have to stay away for 7 days?
So I think this is where testing will be quite handy. I think where you kind of go, what was it? Because if you then go, symptoms resolved, test negative, tick, I can return to work. Whereas you're left in the situation of going, I feel better at day 2, but wasn't it? Could I still be secreting? So it's tricky.
That's exactly the point we're making, and I hope